a community health worker. I am a patient navigator. I'm a survivor of a rare chronic disease. And in November 2019, I had the awesome privilege of becoming the founding executive director of the National Association of Community Health Workers. I want to thank you for taking time out of your day to be with us. And I'm really excited to celebrate this week of webinars that helps the National Association to acknowledge and to celebrate National Public Health Week. If you're a community health worker, you're a peer, an outreach worker, a promotora, a community health representative, a recovery coach, a health educator, a liaison, or any number of the dozens of different titles that comprise our workforce, I want to take a moment and thank you for your service during this pandemic and in a profound time of economic and social disruption. You have been on the front lines for many decades. In fact, the origins of our profession go back hundreds of years in this United States. But I want to thank you so much for all that you have done to innovate, to stretch forward, to create new partnerships and pathways. I want to thank all of our allies who have stood in solidarity and used their platform, their positions, their power, their influence, their values to align with communities during this time. Quickly, let me just say a couple of things. If you are not a member of the National Association, we welcome your membership. We invite your membership. We've got some exciting things that we do for members, including our national learning collaboratives. We have a number of different tools and resources that we offer to you through a special newsletter that's just for members. But we also invite you to any number of our free and open events, such as this one. Quickly, I just want to turn to one of our staff members, Bernadine Mafugo-Jeranyama, who's going to share with you a couple of exciting events coming up this year. And then we're going to quickly introduce our speaker for the day. So wow, we're at 145 folks already. I believe it will continue to grow. What an exciting and critical topic as you're thinking about national Medicaid policy as well as that policy in your own state. So Bernadine, let me hand it over to you.
Thank you, Denise. Good afternoon on the East Coast and good morning everywhere else to everyone. Again, my name is Bernadine Mafugo-Jeranyama. I am NACHWA Senior Communications Associate, and I've been with NACHWA coming up on 2 years, and I've loved every minute of it. So it's great to be in this space with all of you today. I am going to share my screen. Can you all see that? Great. So I'm here to announce that we have officially announced the date for NACHWA's annual meeting and Unity Conference. This is going to be Wednesday, August 3rd to Thursday, August the 4th of 2022. And if you've never been to a Unity Conference or you haven't heard about it, it is the annual meeting and interactive event of the National Association of Community Health Workers, and it's designed for our CHW and ally members making a difference. This event is a wonderful to come together to learn with our peers, connect with them, as well as learn best practices. There will be a lot of interactive workshops where you can learn a lot of things that pertain to the CHW workforce, and that'll include policy, it'll include self-care methods, it'll include research that is being done. So it is an absolutely wonderful way to come and learn together in fellowship. And it'll also include on the first day our annual meeting, where we will have updates about what's been going on with NACHWA, our trajectory, and there's also an opportunity to nominate new board members. So it's very exciting. We would love all of you to be there. At last year's conference, we had over 800 registrants, and we are looking to exceed that this year, and I am very confident we will. We had 70 speakers and co-presenters, and most of our speakers are CHWs. They are people on the ground who are doing the work. We had over 30 workshops and roundtables. We have board members leading roundtables. We have Denise in some roundtables. So it's a really great place to be. And then we also utilize a Slack channel where people can participate in networking. And so this is where people share a lot of their successes. We get to see the events that CHWs are hosting in their states. We get to ask each other, what are some best practices? This is a really great place to be. And this Slack for networking is available after the conference. So you can visit NACHWA Unity. There we go. You can visit nachwaunity.org if you want to learn more about the event. And also, if you want to become a sponsor or know someone that you think would be a great sponsor of this event. So sponsorship allows us to give attendees access to language transcription. We really want this to be accessible to everyone. So we will transcribe every session as well as translating into our most popular languages. It also makes it so that we can have that Slack channel. And this year we want to offer some continuing education credits, which would be our first time doing that. We also want to have some videos of the My Story CHW videos, which are wonderful, the board induction ceremony, as well as our gift box, which we call our swag box. And so for at least the first 200, we're going to confirm probably an additional, there will be a box which has some branded materials and really includes some great self-care items for our CHW attendees and ally attendees as well. And so sponsors will have co-branding on our website. They will be acknowledged throughout, as well as being included in all of our marketing materials. So please take some time, go to www.nachwunity.org. There is on our menu there, you can look at all of the events from last year. There's video recordings. You can take a look at our sponsors, as well as clicking to see this year's sponsor packet. And then keep an eye out. We will be announcing our fully fledged website as we go, as well as the registration date. So you definitely want to know that because you want to get there first. That way you can get a swag box. So thank you for having me. And I look forward to seeing all of you at Unity this year.
Thank you so much, Bernadine. Grateful for, okay, we're recording. We are definitely recording. I just want to thank you so much for your leadership on the conference. The Unity Conference is something that is very special to the CHW and ally community. It was going on for about 19 years before I, came to be a part of NACHW. And it was in different places of the country throughout the year. We've had it virtually for the past 2 years. So I know some of you were asking, am I going to get a chance to go and sort of where is it? It's going to be virtual this year. We didn't feel it would be safe to bring thousands of us together just yet from across the country. But please look for 2023 to be in person, and we are just thrilled to have you. Okay, with that, I just want to quickly move to an exciting part of our agenda, which is to introduce our speaker for the day. I want to introduce a founding board member, a great colleague, and an ally, nationally recognized researcher and professor at Louisiana State University Health Science Center in New Orleans, Ashley Wennerstrom. She is a proud ally of the CHW workforce for over a dozen years. And the way I like to say it is, I had a chance to read Ashley's work before I even came to this organization. So she's been a mentor and a guide to many of us on CHW workforce development and policy research. This is her focus, workforce development and policy. She conducts community academic partnered research and is a promoter of health equity. She's been funded widely by the CDC, the National Institute of Health, Health Resources and Services Administration, and the Patient-Centered Outcomes Research Institute. I'm trying not to use any acronyms, so we're spelling everything out today. Her current work is funded by the Robert Wood Johnson Interdisciplinary Research leaders, and she's a fellow, and she currently co-leads the Louisiana CHW Workforce Coalition, along with fellow founding natural board member, Catherine Haywood. I don't know if Catherine is joining us today, but I just want to give her a big shout out, as well as any other board members who attend. I know they sneak in sometimes. This is an exciting moment for us. And I just want to thank Ashley. About a year ago, no, 2 years ago this time, we did our very first webinar on to certify or not to certify. That was on March 13th of 2020. And I remember our chat started blowing up about the pandemic. We are together once again, and I'm thrilled that Ashley and Catherine, as well as many other contributors to this work, have brought this work forward to all of you. So as I mentioned, as you're watching the presentation, please feel free to put your questions in the chat, and then we will call out some of those questions, so that way you don't forget about them. We are thrilled that you would spend time with us today, and without further ado, the presentation and the stage is yours, Ashley.
All right. Well, thank you so much, Denise, for the incredibly kind introduction. I really appreciate it. Welcome, everyone. I'm really glad to be here today, along with Catherine Haywood, who is my partner in all things community health worker in this world, and particularly in Louisiana. Catherine, do you want to introduce yourself, or do you want me to say a bit about you before we get started?
No, because you're going to say too much. Good morning. Good morning, everyone. I'm Catherine Haywood. I am the Director for Louisiana Community Health Outreach Network in New Orleans and all CHWs across the state. How is that? I work with Ashley, as she just said, and I am a board member of NACHWA, so good to be here.
All right, thanks. Catherine never gives herself enough credit, but she is an incredible national leader, a state leader in all things CHW. I'm very honored to work with her. So before we get started, just want to acknowledge that there are several other folks who have contributed significantly to this work. You'll see their names listed below, a few of which are here today, but just want to acknowledge this is definitely a collaborative project. And also just a quick hello to all of our Louisiana-based CHWs. I saw several of our friends from DePaul Community Health Center and some from the Office of Public Health. So we're very glad that you're here. Thanks for joining us. All right, so today we're going to talk a little bit about community health workers' roles in Medicaid managed care, and sort of why this project matters for community health workers. I'm going to do sort of an overview of the study that we did recently, and then Catherine's going to facilitate our discussion in just a few minutes. And so if you have questions along the way, feel free to put them in the chat, and Catherine, if there's anything that's relevant, feel free to yell them out. I can't really see while I'm presenting. But just to get started, I thought we'd start with kind of a definition of Medicaid managed care. It's a term that gets thrown around a lot, and sometimes we forget exactly what it means, or maybe don't fully understand. So according to the Centers for Medicaid and Medicare Services, managed care is a healthcare delivery system that's organized to manage cost, utilization, and quality. Medicaid managed care provides for the delivery of Medicaid health benefits and additional services through contracted arrangements between state Medicaid agencies and managed care organizations that accept a set per member per month payment for these services. So basically, the way we can think about it is that states don't really want to be in the business of administering Medicaid, and so they contract out with healthcare agencies that run Medicaid programs. A total of 40 states have Medicaid managed care. And what we know is that when states create contracts with managed care organizations, in some cases, they have very specific requirements about community health workers. So sometimes they require that CHWs be hired directly by the MCOs or managed care organizations themselves. Or sometimes the states require that managed care organizations have contracts with community-based organizations or other types of agencies to hire CHWs and provide CHW services through those other types of entities. Some states don't have any particular requirements that their managed care organizations have CHWs. But oftentimes, managed care organizations choose to hire CHWs because they know how effective CHWs are in improving health outcomes. So I can use Louisiana as an example of that. Catherine and I are both here in Louisiana. We've been here for many years, and we noticed right around 2016, when our state expanded Medicaid, that suddenly all of the managed care organizations started hiring community health workers. And there wasn't any particular requirement in the contract at that point about CHWs, but we saw that they were hiring CHWs really to focus on doing outreach and enrollment to get folks in to these new managed care plans. And so one thing that we started sort of thinking about is, well, gee, if some of these organizations hadn't previously had CHWs involved, what are their roles in managed care, and what's going to happen after sort of this initial period where in our state we saw a lot of CHWs being hired to focus on outreach and enrollment. We knew at some point folks would be enrolled, and then we were curious about what would happen to those CHW roles. So that's part of what sort of predated the study or got us into this line of thinking. And again, we know that Medicaid managed care organizations exist in 40 states. And so we really wanted to look at what was going on nationally, because there hasn't been a lot of research into what's going on at these Medicaid managed care organizations in terms of CHW roles. So that's what we're going to talk a little bit more about today. If I can get my slides to advance. All right, so we had a couple of sort of major questions that we wanted to answer with this work. And one is just, what are the demographics, roles, and responsibilities of community health workers who are supported by Medicaid managed care? And the next is, are there differences between CHWs who are working directly at the Medicaid managed care organizations versus those CHWs who are contracted at other organizations? So for example, those who might work at community-based organizations or health departments or other types of organizations, but are not working directly for the MCOs themselves. So those are some of the things that we wanted to look into. So how do we do this study? Our methods included that we decided to do a national survey. So we developed a couple of different surveys, one specifically for community health workers themselves, and then one for supervisors of CHWs, including sort of direct supervisors and also administrators at Medicaid managed care organizations. And both LaShawn and NACHWA staff participated in developing those surveys. We're really focused on making sure that we had lots of good CHW input into our survey questions to make sure that we were asking the right kinds of questions and using language that would be appropriate. So Catherine and her team over at LaShawn, and then Denise and her team at the National Association of CHWs, or NACHWA, had lots of input as well. So that was helpful. And so then we did what CHWs do a lot of, which is outreach. So we distributed our survey through LaShawn as well as through NACHWA. And also by making contact with about 20 community health worker networks nationwide. We also contacted about a dozen national stakeholder organizations to request their support in distributing this survey. So I really can't thank you all enough. I know I don't have time to list every single organization that helped us out with distributing the survey, but I must acknowledge that we could not have done it without you, the local, state, regional CHW networks that distributed the survey for us to their member groups, and then also to some of the national stakeholder organizations. So we're very, very grateful for that. In order to be able to participate in the survey, we had some sort of eligibility criteria. So the folks who answered the survey had to be either a CHW or a CHW supervisor or administrator that was working at a Medicaid managed care organization, or a CHW or CHW supervisor that was working at an organization that received some kind of contract from a Medicaid managed care organization to provide CHW services. And I won't go into all the details on our on our statistical analysis, but just briefly, what we did is we calculated some descriptive statistics from the answers that we received. And then we also used some statistical tests called chi-squares or Fisher's exact tests to look for differences between the groups, which I'll talk about in a little bit. And just one quick note, I'll mention that I'm going to talk a little bit about statistical significance, which basically just means when we're looking at differences between two groups, we want to have some way to test whether the groups are different or similar. And we want to look at if they are different, are they different just sort of by random chance, or do we have sort of enough mathematical power to prove that there really truly is a difference and we're not just seeing sort of a random difference that could be attributed to chance. So on all the slides that are coming up, you'll see green stars when we see something that is statistically significantly different. Okay. So our results, what did we find? So after distributing this survey, and I should say we did this last spring, early summer, we had a total of 146 community health workers who responded, and they came from 29 states. And you'll see on the little map here, the darker the color, the more respondents we had. So we had the largest number of respondents from North Carolina, also quite a few respondents from Pennsylvania and Ohio, some good representation from our friends in Louisiana, and some good representation also from California. But any shade of blue that you see here means that we got some representation from those CHWs. So we were excited about that. We also had 55 responses from employers or supervisors who worked in 34 states. So we were really happy with this representation. It's a relatively small number overall, but given that there are 40 managed care states and we got CHWs from 29 states and supervisors from 55 states, we felt like that was pretty good. All right, so let's talk a little about what we found in our survey. So again, one of the things that we wanted to know, just sort of basic demographics about CHWs who are working with Medicaid managed care. So among the folks who answered our survey, just over 35% of them were working directly at a Medicaid managed care organization, and the rest, so around 60%, a little over 60%, were working at some other type of organization that was receiving a contract for services from MCOs. So just about 1/5 of those were working at community-based organizations. Around 17% were working at hospitals, and around 15% were working at federally qualified health centers. And then about 6 or 7% were working at health departments, again, receiving contracts for services from Medicaid managed care organizations. We asked, of course, about gender, just to learn about basic demographics. Over 90% of the folks who answered our survey were women. That was not too surprising. That's pretty consistent with national research. We also asked people to identify in terms of race or ethnicity. And of course, folks were allowed to pick as many races or ethnicities as they wanted. So you'll see this total's a little bit more than 100%. But just around 40% said that they were African-American or Black. About 30% were white. 25% identified as Hispanic or Latinx, and about 4% identified as Native American, and then less than 1% identified as the remaining races or ethnicities. We also asked folks about their education level. And we found overall that this is a pretty educated group. So about 38% of the people who responded to our survey had some college or a 2-year degree. Another 38% had a bachelor's degree, and then about 13% had a graduate or professional degree. So I would say this was generally higher than what we see in national surveys of CHWs. All right, and so then we asked about years of experience as a CHW, and here we started to compare some of the differences between those who are working at a Medicaid managed care organization versus some other type of organization. So again, community-based organizations, federally qualified health centers, health departments, things like that. So what you'll see in this chart and all the ones that are going to follow is that the blue charts, or sorry, the blue little bars represent the folks who are working directly at MCOs, and the orange ones are for people who are receiving contracts at other types of organizations. So overall, what we found is that community health workers in our entire sample had roughly just about 3 years of experience as a CHW. And we found that MCOs were significantly more likely to have community health workers with more experience than other agency types. So you can kind of see that here. This over on the left is 0 to 1 years of experience. Here we have 2 to 4 experience, and then 5+ years of experience. So we're seeing that our Medicaid managed care organizations have CHWs with more experience. I'll also note here, just thought it was interesting that about 18% of the people in our sample said they have another job in addition to the work that they're doing as a community health worker, receiving support from Medicaid managed care organizations. All right, we also asked about income, always an important factor in our lives and work, and something that we want to be attentive to when we're thinking in terms of supporting a workforce and making sure that people are making not just living, but as Denise always talks about, or often talks about, is thriving wages, right? And so what we found here, you see the green star, which indicates that there is a significant difference. We saw a really significant difference in the amount of money that people are making based on whether they work at a Medicaid managed care organization or another type of organization. So I won't go through every single statistic here, but the main theme that you want to get from this particular slide is that folks who are working for managed care, again, represented by these blue bars, were more likely to have higher income. So about 20% of those working at MCOs made between $40,000 and $49,000 a year. Another 5% made between $50,000 and $59,000 per year. And then just under 5% actually made $60,000 or more. So again, we're seeing that CHWs who are working at other types of organizations that are receiving contracts are generally making less money. All right, we also asked about the benefits that were offered by Medicaid managed care organizations versus these other types of organizations that are getting contracts from Medicaid managed care organizations. And overall, what we found is that in almost every single benefit category, CHWs who are working directly for Medicaid managed care organizations are getting better benefits. And so some of those benefits include things like paid time off, transportation allowance, health insurance, some kind of disability or life insurance. They said they're more likely to get raises, they're more likely to get tuition reimbursement, as well as retirement and paid parental leave. So again, overall, the folks who are working directly for Medicaid managed care organizations are receiving more benefits than those who are not. We also were curious to learn a little bit about what kind of training was being offered by employers. So we asked about a whole bunch of different types of training that potentially could be offered. And we found that for a few types, those who were working at Medicaid managed care organizations said they were more likely to receive training in motivational interviewing, in issues related to chronic disease management, specific health topics. So when I say that, that could be, maybe they were more likely to get training in something like how to manage asthma or diabetes, things like that. They were also more likely to get training in advocacy as well as leadership. So some differences in the way CHWs are trained, whether they're working directly on a Medicaid managed care organization or at some other type of organization that's receiving contracts. And then we also asked them about whether they were addressing any specific health conditions, and we found a few significant differences. So the CHWs who are working at MCOs were more likely to be working directly with individuals who have diabetes, those who have some sort of mental health condition, folks who have asthma, and then also they were more likely to be working on issues related to maternal and infant health. So I think it's interesting to note that there are those differences there, particularly when we notice that a lot of those conditions tend to be pretty high cost, which may be a priority of Medicaid managed care organizations to address those high cost issues. We also wanted to know just, what were the roles that community health workers were doing? So we asked specifically about the roles that are outlined in the Community Health Worker Core Consensus Project. I know many of you are familiar with that. If you're not, it's a great resource, and you can always look that up at c3project.org. But what we found were a few significant differences here as well. So the folks who were working at Medicaid managed care organizations were significantly more likely to be involved in providing some sort of coaching and social support for the folks that they were interacting with. And they were also more likely to be involved in conducting either individual or community assessments. And then the only other place that we saw a significant difference is that folks who are working in some other kind of organization, like a federally qualified health center or a community-based organization, were more likely to be involved in providing some sort of direct service. We asked as well about specific roles and responsibilities of CHWs, and we found a couple significant differences. One is that CHWs working at MCOs were more likely to conduct health screenings, and they were also slightly more likely to receive referrals for home visits. We asked about a whole bunch of different types of services or resources that CHWs might offer. Most of these are related to social determinants of health. And the only one that we really found a difference in was that CHWs were more likely to connect folks to transportation if they worked at a Medicaid managed care organization as opposed to one that receives contracts. And then we asked about various types of populations that might be served. And we found a lot of differences here, which were kind of interesting. So we found that CHWs working directly at the Medicaid managed care organizations were more likely to serve populations who had history of frequent hospitalization, folks who had frequent use of the emergency department, people who identified as not having a primary care provider, people who were unhoused, people who were experiencing some sort of substance use disorder, people who are pregnant, as well as children, and then folks with a disability and people with a history of incarceration. And then finally, we asked about whether CHWs were working with specific racial or ethnic populations. And we found that those who are working in other types of organizations like community-based organizations and federally qualified health centers were much, much more likely to be working with populations that identified as Black or African American or Hispanic or Latinx. So I promise that I will not bore you with any more charts. I have just a couple more quick tables I want to show you, and then we can move on to the discussion. We also asked some questions about whether CHWs who were being supported by Medicaid managed care felt valued by their organization. And I know there's a lot of numbers on this particular slide, so I hope it's not too rough to look at, but just want to highlight a couple of things. So one of the questions we asked is whether CHWs felt like they had opportunities for promotion at their organization. And almost 8% just said that question was completely non-applicable, which I think is really interesting because it suggests that there may not be any opportunities for promotion whatsoever. And then there were another 14% who completely disagreed, and another 16% who somewhat disagreed with that. So overall, we're looking at almost a third of CHWs who don't seem to think that they have any opportunity for advancement at their organization. We also asked a question about whether CHWs feel like they're utilized to their full potential. And what we see there is really almost a quarter are saying that they disagree or somewhat disagree with that statement. So they're feeling like they're not really being fully utilized to their potential. And similar percentages on a question about whether they're equitably compensated for their work. So almost a quarter are saying that they don't feel like they are equitably compensated. And this is our sample as a whole. This is not divided by those who are working directly at MCOs versus other types of organizations. I mentioned earlier that we did also survey supervisors. We've been primarily talking about just the results from the CHW portion of the survey, but I did want to share this as well. So this was responses to the same questions when we asked the supervisor version of it. So we asked them whether they felt that CHWs have opportunities for promotion. And again, we're seeing really almost a third of supervisors are sort of confirming what CHWs had already said, which is that there really don't seem to be any opportunities for promotion. We asked a similar question about whether CHWs are utilized to their full potential. And about a quarter disagreed with that somewhat, and another almost 4% disagreed completely. So pretty, strong percentage of folks who are saying that CHWs aren't being utilized to their full potential. And then similarly, we asked a question about whether CHWs are equitably compensated. And, really looks like almost 40% are saying that CHWs, or over 40% are saying that CHWs are not really equitably compensated, or that question is just not applicable, which is somewhat distressing. So those are some of our findings. We move on to our next slide. Okay, and now I'm going to turn things over to Catherine, who's going to talk a little bit about some of the limitations of our study, and then she will ask some questions to kind of facilitate our discussion here.
I'm back, y'all. So, but before I get into that, I want to thank Carl for answering all of these questions about Medicaid and Medicare and how they fit into different states and what's going on. Thank you, Carl, so much. We appreciate that. So of course, there are limitations in the cross-sectional study design. We had a small sample size, and I think Ashley mentioned that in the beginning of the presentation. So the size wasn't as large, even though I think it was like 29 states or whatever we received results from, but it wasn't all of them. So the size could have been larger. Of course, CHWs involved in CHW networks are more likely to have responded. And yes, they did, more likely. And a lot of them, I think, self-reported. So the limitations were there. Could have been a little bit better in some things, and so that's that. Yeah. So we go to the next one. All right. We have some questions for you guys. All of the CHWs represented here are supported by Medicaid. Why do you think we see differences in some of the populations served and health conditions addressed between the CHWs who work at an MCO versus CHWs who work at organizations that receive contracts from MCOs? So if you want to answer this outright, I think Peter will take you off of mute, and you can discuss this with us. You guys got a lot of questions going on in this
Oh,
chat.
Erin raised her hand. Erin, do you want to come off mute?
Yes. Thank you, Denise.
Sure. Erin, can you hear us?
Yes, I can.
Great. We'd love to hear your response.
Sure. So I think my limited experience, I've worked for insurance companies, and I've also worked for, within the community. And so I think MCOs, the CHWs are going to be more focused on dealing with claims and things that are coming into the insurance company, and they're going to be targeting those specific things versus somebody that works at a community organization such as like a local health department or something like that is going to be focused on more of the outreach and things like that. So
thank you, Erin. I see
so Gloria has raised her hand as well.
Okay. Just one quick thing, Gloria. Stay right there, Gloria. Don't go anywhere. But okay. All right. There's a statement that says it could be that MCOs design their approaches and priorities based on primary cost reduction. So I just wanted I can see some of the chat. So yes. All right, Gloria, I'm listening. We're listening.
I'm a community health worker in Greensboro, North Carolina. And
Mhm.
we, the clinic that we work through with community health clinic, Mustard Seed and Cone Health. When I started, I've been working with them for 4 years. Uh, they had applied for a grant, Shield Foundation, and as a result of that grant, the person that was in charge here, she received another grant. So that's how we're supported through that. And each year, they have a fundraiser, and the lady that writes the grant, she's managed to get a different grant. We just started out with a new grant in January, and it's a 2-year grant for support. And actually, the grant that she wrote right now with Greensboro, and we're the only community health workers, and there are 3 of us at that work. And she's in the process of getting another grant because we found out during COVID that there are areas in the community and out in the rural areas, so Gifford County, that there's a need for community health workers, but we are not able to reach out to them because basically we're Greensboro and surrounding areas of Greensboro. So, but we're being supported, not by Medicaid, it's through grants that we are being supported by, along with Cone Health.
Thank you, Gloria.
So we have,
Hopefully the grant that she's working on, you guys will get that one. I think Kelsey, am I right, Denise?
yes, Kelsey was, she just learned how to raise her hand in Zoom, and she is next up, and then we'll go to Amy, Pamela, and then Charlie Crooms.
Okay, thank you.
Hey, everybody. I am in Iowa. So I previously worked for the Medicaid MCO in a mental health outreach capacity, but I've also worked in organizations as an outreach worker. And the energy, the work environment, the atmosphere, and the attitude about serving people could not be more different in the MCO world and the organizations that are receiving maybe reimbursement from MCOs. Night and day difference in the attitude and the desire to help people and walk alongside people. The MCOs I found were very money oriented, and like I think Catherine had mentioned, it is really fueled by money and what things can we pinpoint where that service is costing X amount of dollars. Like, we need to get them off that service. We need to get them through the system, go, go, go. Whereas when I worked at the organization and someone mentioned grants, it was more grant funded to give us that flexibility and freedom to say, what does this person need? How can we best serve them? What are the actual tangible boots on the ground to support them and walk alongside them? I just felt that overall the MCO is very tied to the finances, yes, but also like paperwork and bureaucracy and the powers that be, quote unquote, you know, this fear of how much are we spending on that member, where the organization does not have that mindset at all. It's how can we serve that member? So it's very different. My answer would be bureaucracy and money, and that hurts my heart. So that's my input. It's very interesting to have worked on both ends. So yeah.
Thanks, Kelsey. We appreciate that. And I see somebody's agreeing with you. Yeah, thank you. Who's up next?
So we have a
people.
couple people have raised their hand. We have a number of questions in the
Yeah.
chat. Let me ask a quick question in the chat, which is, did the survey capture information such as additional credentials among CHWs? For example, what percentage or number of CHWs are also medical assistants? You know, are they CNAs? Are they providing another role? And I think a related question to that is around the educational advancement. We saw more MCOs who had CHWs with bachelor's degrees. And so I just wonder if that, you know, if they're sort of sorting for CHWs with bachelor's degrees and not recruiting, not hiring CHWs who don't have, to Duana's point, also an MA, or they're not also a CNA. Can you all speak to that?
Yeah, I can say we didn't think to ask that question, and darn it, I wish we had, but no, we did not ask about additional qualifications that CHWs had. We did ask a question that's not reflected here, and I don't want to tell you the wrong information because I don't remember the answer offhand, but we did ask a question of the supervisors, what the requirements were, educational requirements were to hire CHWs, and don't quote me on this, I think it was something around, it was, most of them said it was like a high school degree or equivalent. There were not very many that said they required a bachelor's degree. However, I would suspect that, you know, if they get 2 applications that are otherwise equal, that they're more likely to hire the folks who do have a bachelor's degree.
I also would think it might be experience versus whatever. I can have a bachelor's degree just coming out, get some training and say I'm a community health worker, but I also could have just a high school education, but I have been doing this work for whatever number of years and I have the experience. So I think they may look at that also. And again, like Ashley, those are, to be honest, that's my thoughts. I don't know for sure. And we didn't really ask that question. So yeah. All right, Denise, where are we? Because I know we have, what, 3 more
we've
questions?
got Amy, Pamela, and Charlie. It's we're coming up on the last 10 minutes. So bring your questions forward and let's hope that we can get those answered.
Okay.
Amy?
Thank you. My name is Amy and I work in Spokane at a community action agency. And I think in response to the discussion question, we're kind of a newer CHW department, and we've kind of focused on one kind of SDOH need, like transportation. So we offer transportation, but in response to a recent community needs assessment that the agency did, we're looking at kind of expanding our role, the CHW's role here, and we're all grant funded. So I really appreciate what Kelsey shared about the difference between working for a managed care organization and a community-based agency. We are, the crew here is very client focused. And so I'm grateful that we have the opportunity to do that being in a community-based organization. And there's also the challenge of funding and staying funded for projects, in this situation. So, and thank you to the presenters. This has been fantastic.
Thank you, Amy. Somebody is up. We have a couple of more questions, but who's next?
Yes, Pamela and then Charlie.
Okay, Pamela.
Good afternoon, everyone. From upstate New York, it looks a little bit different because of Medicaid redesign, the 6 years prior to COVID. And then obviously COVID made all of our services look incredibly different. So we're in a space and time right now where we don't get the fee for service revenue under Medicaid redesign. And we've had to aggressively write grants in about a 90-day period to rebuild a team that I lost during COVID. And we will have now a 2-year period where we're working with an emerging IPA who become the convener. They are negotiating with the MCOs and with some hospital systems or federally qualified health centers that want the CHW model. So we are getting a 2-year grant under that special pilot project, which we hope will move us closer to value-based payment. which again is hopefully a sustainability model for what we've built over time on a shoestring grant funded budget. I concur with what everyone is saying. From we always need to be the advocate to be person first. That is so important to us. It doesn't matter what population we are working with, that person needs to be honored and respected, and they should be in the driver's seat. They've earned it. They need to be there. And we can't do anything if we don't start with them. So that's really at the core of what we do here in upstate New York. Secondly, it's equally important that we know that the social determinants of health drive 80% of those health outcomes. And we're never going to get to the place of, but as community-based organizations, do we get 80% of that earned revenue, or of that saved revenue, or of that reimbursement? Because we are decreasing emergency room utilizations, decreasing hospital admissions, decreasing length of stay in hospital. And unfortunately, that answer is no. And so, but what do we do to get closer to a better balance on the payment side? Because the hospitals don't have the money and won't pay for it, and saying they've lost revenue. The MCOs have not lost revenue. They're the ones sitting on the revenue, but they won't let go of the purse strings. And they've started to hire their own CHWs and telling us, but you can't call them community health workers. I'm like, oh, yes, I can. And I will. And I will not stop calling them that. This is my 40-year profession. You can't change, what we've built here. And we've built it, strong and resilient, just like the people that we are so blessed to serve. So thank you for being part of that journey. I hear a lot of like-mindedness, and the battle isn't over yet. So I'm from upstate rural New York. It's on the Pennsylvania border. We're about 15 minutes, but we work in a 9-county region that radiates east, west, and north. So we go almost from Binghamton to Syracuse, from Binghamton to the eastern side of Delaware County, which is 2.5 hours away, and to the west as far as Steuben, not quite to the Rochester area, if that makes sense.
Thank you, Pamela. I want to try to get in 1 or 2 more questions from Charlie and or Cynthia, if you all can unmute. We have just about 6 minutes, so I would lift up your question quickly if you'd like an answer from Catherine or Ashley.
Hello, can you hear me?
Yes.
Hi, I'm Charlie Crooms. I'm in Palmer, Alaska. Well, actually, I'm in Wasilla right now, but my comment was more to the question that was asked quite a while back now. The difference between people who work for directly for MCOs and the people that work for organizations that receive funding from MCOs. MCOs are directly federally based. So they're more tied to, as someone said, the bureaucracy, the red tape. They have a specific, how do I want to say, outline that they have to follow. The companies that receive the money from the MCOs are grant-based. They have to go out and find the particular hotspots at the time to be able to justify needing that grant to get the funding to hire the people. Hopefully I'm close to right on that, but I'm not sure. I would really love your feedback.
I think you're right. If it's a grant, yeah, I think you're correct. Others may not. Denise, yes. Oh, Denise is answering something else. But yeah, I think you're right, Charlie. So. And I also think if you put your question in the chat, whatever, Denise might be able to send us that and we can answer it a little bit more. So I think we're going to move on, unless there was somebody right after Charlie, to the last question, because we only have like 6 minutes. I think.
Cynthia also had a hand raised.
Yeah, I can come off mute and just
Great.
very briefly ask my question. I am the co-founder of Culture Care Collective, which is a hybrid health support program that partners with community health workers to integrate them into hospital-based care teams. And we've been fortunate enough to be accepted into the Mass Challenge Health Tech cohort, where in our accelerator, we have a partnership with the U.S. Department of Health and Human Services. And in this partnership, we have a lot of influence on policy development, especially as it pertains to integrating community health workers into clinic-based settings. And I just wanted to, gauge the perspective of the room to see how we, myself as a former community health worker and now as a public health nurse and, co-founder of this company, how can we really support community health workers, sustainable funding in a community-based organization with a business model? How can we advocate for sustainable funding, but then also, equitable models in which community health workers and patient-centric care is valued in these Medicaid-based contracts that we are seeking?
You heard
Yeah,
how I
so
said that's a good question. Denise,
yeah, it is. It's a big question, and I know we just have a couple of minutes. Let me say one or two sentences, and maybe we can just go around. So the first thing I would say is that sustainability has not been well defined. Most people think of sustainability just as financing. And so the first thing that I would sort of advocate for in this role that you have is to expand the definition of sustainability so that we think about, first of all, a thriving wage. We don't just want to integrate CHWs into services, but then they're making a minimum wage, right? And as Ashley said, they have to go get another job. So that's one way to consider sustainability. Another is career pathways, career ladders. What does it mean for a CHW to remain in an organization and to have advancement? And NACHWA, we have helped to collect some national data that we're going to be sharing soon about what CHWs think about that. They want to retain their title as CHWs. They want to be involved in program design. They want to be able to co-write grants. They want to be able to contribute to research like Catherine, like myself. So there are other things to consider. There are also other aspects of sustainability. One of them is, and Catherine is a great example through the leadership of LaShawn, to have a state-based mentoring organization that is a professional association for mentoring, for continuing education. So financing is a piece, but I don't think it's the only piece. The last thing I would say is that NACHWA and many other organizations, including LaShawn, we advance and promote the core competencies from the CHW Core Consensus Project. In other words, we want to see CHWs operating at their highest scope, just as other professions want to work at their highest scope. So we're not just here for a downstream work, deliver this flyer, complete this intake. We want to be involved in the design and the development of these interventions. And someone said earlier that up to 80% of what impacts a person's health happens outside of a doctor's office, outside of a medical treatment, or outside of a prescription. That's what we call the social determinants of health. So we have to invest more of that money in community, more of that money into a community-based workforce, and CHWs are chief among those. And I think we'll have better outcomes. I think we'll prevent disease and hospitalizations and ER visits. And I think we'll get better quality as well. Ashley, Catherine, let me just thank you for your diligent work in bringing this data forward. And what would you say about sustainability? What's sustainability for each of you in about a minute for the CHW profession?
Number one is we have to, and we're constantly talking about sustainability and how that looks, how we're going to have it, whatever. Number one is I do feel we need to advocate more, but that's an ongoing, it's ongoing, never stop. You have to continue. I don't think we're going to ever stop, because that's a big question. And we're all trying to work on that. And I'm not sure if we all have an answer to that yet, but we are working on it. Nationally, are you there?
I am. It's a tough question to answer. I mean, I echo everything that's been said already. So I'll just say from my perspective as an ally, sustainability will happen when I don't have to be in the room anymore, when I don't have to say, hey, why aren't CHWs here anymore? And CHWs are given the respect, financing opportunities for development that they deserve. So yeah, hopefully I'll be out of a job soon enough.
Okay, it's going to be a while around sustainability. If that's what's going to put you out of job, don't worry about it. It's not fixing to happen. Denise, before you say anything, I want to thank everybody. I think the conversation and the chat, I've been trying to listen to that and read what's in the chat. It's been great. I think we're sorry that we couldn't get to all the questions, but the first question, everybody responded to, and we appreciate that. Thank you very much.
Yeah, I want to thank everyone for joining us today on the first webinar to celebrate National Public Health Week. If you received our newsletter, then you know that at 2 o'clock today, we have another excellent webinar from the Refugee Dream Center in Rhode Island. If you want to understand the life and experience of a refugee from the Gambia who came to the United States, founded a nonprofit, and it recruited other refugees and immigrants who came to the United States to become community health workers in their community. You're going to hear some amazing life stories. And I would love for you to join us at 2 o'clock Eastern Standard Time today if you're available. We also have 2 great webinars tomorrow. One is completely in Spanish, and it's focused on trauma and domestic violence. And then we've got an exciting webinar that we co-partner with the American Public Health Association CHW section on some new policy around CHWs. So you do not want to miss it. Check our newsletter. You can go on our website. Our newsletter is completely free, by the way. So sign up. Yes, you'll get slide links, and yes, you'll get the recording, but please connect with us. Let us know what you're doing. We will receive the chat, and I'll ask Ashley and Catherine to sort of go through and see if we can answer additional questions. Maybe we'll pull together an FAQ. This is a critical conversation that we're having right now as our profession has come to unprecedented prominence. But we know that this is a moment, okay? And what you all are talking about is the movement. It's a thriving wage. It's racial equity, right? It's career advancement. It's all of these things that bring sustainability for everyone. And so we hope to see you in future events. Ashley and Catherine, thank you again for your time, and all the other researchers who helped to pull your work together. Thanks, everyone. Stay safe, and we pray that all is well with you.
Bye, everyone. Thank you.